Well, good afternoon. Thank you for joining us for the second Three Deans lecture. And my name is Lori Pupjoy, and I'm the Dean of the St. Clair School of Nursing. Last year was the inaugural Three Deans lecture series. And this series is supported by Dean Richard Barron, School of Medicine, Dean Christopher Haglund, College of Health Sciences, and the St. Clair School of Nursing. The purpose of this lecture series is to explore broad topics in healthcare that make us think differently and offer perspectives that impact education, research, and practice in our college. Schools, colleges, and health systems. I first heard of Dr. Sexton's work when our Associate Dean of Research, Dr. Whitney Tevis, she returned from a conference where he had spoken on well-being, and she immediately understood the vital nature of his work and wanted to bring him to MU to speak. Dr. Sexton is also well known to our close colleague, Dr. Sue Scott, who is a national expert in the second victim experience. And for those of you who are not familiar with that term, the second victim of adverse patient events is the healthcare worker who needs support to recover from that experience. The timing of this lecture could not be better. Each of the schools, colleges, and MU Health is working to improve the well-being of our most precious resource, our staff, faculty, and students. And we are excited to have this well-known and respected national thought leader with us today. Thank you. Dr. Sexton is the director of the Duke Center for the Advancement of Wellbeing Science. He leads the efforts around research, training, and coaching, guiding quality improvement and well-being activities. A psychologist member of the Department of Psychiatry, he is a psychometrician and spends time developing methods of assessing and improving safety culture, teamwork, leadership, and especially workforce well-being. Currently, he is disseminating the results from a successful NIH R01 grant that used randomized control trials to show that we can cause enduring improvements in healthcare worker well-being. Perpetually recovering, father of four, he enjoys running, using hand tools on wood, books on Audible, and hearing particularly good explanations of extremely complicated topics. Please join me in welcoming Dr. Bryan Sexton to the University of Missouri.
Well, thank you very much. I appreciate this. It's such a pleasure to kind of get to hang out with y'all, and in particular, Sue Scott, who is somebody I've been admiring for a very long time in her work. Real quick, I hope to just in the next kind of 40 minutes or so share with you some ways of thinking about well-being that perhaps you haven't thought about. And then also to let you know there is some good news on the horizon and that there are some great free resources that I think you can share. And we'll also talk about our monthly series as well. So just for the next 40 minutes, please don't think about well-being as how happy you are. Instead, think about well-being as your ability to do stuff. So as your well-being is compromised, your ability to do stuff is compromised. No wonder healthcare worker well-being predicts all kinds of clinical and operational outcomes. It's just an indicator of your ability to do stuff. With that in mind, I really like this research by Jim White and some colleagues at UCLA and at Duke, where they've looked at biological age and chronological age. And they've been doing this work in mammals, rats and dogs and humans for a long time. And what they've shown is that if you take a mammal and you severely stress out that mammal, you increase the biological age beyond the chronological age of that mammal. I'm a 51-year-old man, and so if I'm undergoing trauma surgery, right, or if I have a severe case of COVID, I may look biologically like a 60 or a 65-year-old man. But if you give me an opportunity to recover, I can go back to looking biologically like a 51-year-old man. Does that make sense so far? The problem is that in healthcare, we have a very powerful culture where we blow right past the point where we should be stopping to do that recovery. We wait till we're hanging off the edge of the cliff by our fingertips. We can barely keep our eyes open. We're so exhausted. We can't make another decision to save our lives. And then we say, I should probably take a break soon, and then you still don't. And that's the norm so much now. I like the quote from Maya Angelou. She said, each person deserves a day away in which no problems are confronted, no solutions are searched for. Each of us needs to withdraw from cares which will not withdraw from us. Only if we would actually do that. So I'll start at the beginning, and I wanted to take a wild ride through the literature here. First and foremost, if you want to talk about well-being, you got to talk about work-life integration. The very best indicator we have right now for what your well-being will look like next year is your work-life integration norms right now. And now, are you satisfied with work-life integration? Because a lot of physician well-being research looks at work-life satisfaction, which predicts marital satisfaction and life satisfaction relatively well, but it doesn't actually predict well-being. It's only a mediocre predictor of well-being. Instead, you look at not how satisfied, but rather how often do you do certain things that infringe upon your work life. That is a very good job of predicting your current and your future well-being. So let me give you an example of that. We created this metric for work-life climate with our fellow Stephanie Schwartz at the time. And we did this across a bunch of different healthcare work settings at Duke. We published our dirty laundry. I'll share it with you right now. Start my video. Do I want to start my video?
Oh, yes, please.
Yes.
Thank you.
Okay.
Wonderful. Thank you so much.
Happy to. Okay, so in the past week, how many of you, for example, just to be clear, skipped a meal? Anybody skip a meal in the past week? I know I did. How's that diet working out for everybody? Or how many of you ate a poorly balanced meal? Anybody eat a poorly balanced meal or worked through a day without any breaks, right? Nature called and you ignored it, or got home late from work. Anybody get home late from work one of the days in the past week? That's a fun one. Had difficulty sleeping 1.7 days, or changed plans because of work. Did anybody change plans because of work? Or how about felt frustrated by technology that used to be on the list? We had a lot of ethic, and now that's a big one for us. Or got less than 5 hours of sleep during the past. These are the work-life balance items that we use to tell us where things are with your well-being. We can create a scale score from these behavioral frequencies, not satisfaction with, but how often you do it. It tells us a lot about your current well-being and your future well-being. Now, to that end, we can look across 396 different work settings and see, and we can actually see on the left-hand side, you can see there's not a lot of, there's actually terrible work-life balance on the left. And on the right, you can see 100% are reporting pretty good work-life balance. And it depends on what work setting you're in. Actually, there's too much variation in this for it to be by chance. I was taught in my training that good work-life integration, you have to say no and draw good boundaries and set limits for yourself. And actually, that clearly is not being reflected by this kind of variation from one work setting to the next. In fact, whether or not you pee at work depends on whether or not your colleagues pee at work. Whether or not you eat lunch depends on whether or not your colleagues eat lunch, or whether or not you leave on time depends on whether or not your colleagues leave on time. That's no longer an individual business. That is a norm. That's a climate. And that's what's reflected in here. So we actually found the first evidence in that publication for the social contagion of well-being metrics. Now, we do see some variation by roles. You can see over here, our physicians, residents, fellows, and attendings have the worst work-life integration of anybody. And then you have nurses kind of here in the middle, and over here on the right-hand side, you see dietitians and nutritionists. There is not nearly as much variation by role as there is by work setting. There is some variation by how long you've been in your current specialty. If you've been in your current specialty for less than 6 months, you've got pretty good work-life integration. It takes about 6 months to kill your spirit, and then you look like everybody else. Then you have people who work days tend to have better work-life integration. People who 8-hour shifts tend to have better work-life integration. But really, the real juice there is work setting level is where all the action is at. It doesn't matter what your background is. It matters where you work as to what your well-being index looks like. So is there social contagion for work-life integration? Yes, there is. Let's kind of continue that thought on. I'd like to share with you a little bit of the data from emotional exhaustion. So emotional exhaustion is the most frequent way that we measure well-being in the medical literature. It comes from Maslow inventory. It's highly validated. It's very good. And I've used it in my research as well. Emotional exhaustion in healthcare workers does a good job of predicting patient engagement, infection rates, medication error rates, and standardized mortality ratios. And this slide I made in 2012. This is not new. We've known this for a long time. To become more current, we now know, this is a JAMA Network Open article that was published just a few months ago, that nurse burnout in this systematic review is a big predictor of all the same stuff, and it's with much larger data sets. And so if you want like one slide that talks about a whole bunch of bad things related to nurse emotional exhaustion, that's a good one to use. We have in our lab been tracking well-being for the same 30,000 healthcare workers for a long time. So we published this in JAMA Network Open right after the pandemic ended. And so for these 30,000 people, we tracked them into September of 2019. So that's before the pandemic. September of 2020, so during the pandemic, but before vaccines. Remember that? That was a fun minute. And then in September of 21, that's after vaccine mandates and after Delta and during Omicron. Right? So the same 30,000 people, but three very different times. And what did we find? We found that our nurses started off at the high level of emotional exhaustion to begin with. They went up in the first year and up again in the second year of the pandemic. Our physicians are very different. Our physicians actually went down in the first year of the pandemic, likely due to a decrease in volumes, increased use of telehealth. Suddenly, leaders are interested in what physicians have to say. And it was a great time to be a physician. My best friend at Duke is an interventional radiologist. And for the first time in his career, he was having dinner with his two daughters and his wife 2 or 3 times a week. Never happened before. Hasn't happened since. That was a unique thing that happened in 2020. Look at from 2020 to 21. That 10-point increase in emotional exhaustion is the largest one-year increase in exhaustion ever reported anywhere in the literature. And so the bottom line there is whether you're a physician or a nurse or anybody else, regardless of where you started, by the end of the pandemic, you're worse off. So the physicians lost their gains that were kind of quick earned gains, and they're worse off. Now this ends in the fall of 2021. What I can tell you now, we haven't published this yet, but we're submitting it for publication soon, is that nurses continue to inch up further. So nurse burnout rates, we were talking about this morning. Nurse burnout rates are now about 54% are emotionally exhausted. That's just one of 3 variations of burnout. That's not all burnout. That's just that one type of burnout. Physicians now are at 49%. So physicians now are much higher than they were at the end of this study period. So physicians are catching up to the nurses in terms of the feeling depleted, feeling very, very depleted. But that's not published yet. That's just, and that's a big data set. It's about 200,000 healthcare workers in that data set. So for every 1 point increase in emotional exhaustion, and this is Lottie Derby's work out of the University of Colorado, she's shown that for every 1 point increase in emotional exhaustion, you're 20% more likely to step away from the bedside. And what I just showed you from our data, if I can take that overall bar there at the top and I can blow that up, that's almost a 9-point increase. But no wonder 1 point makes it 20% more likely that you step away from the bedside. No wonder it's hard to keep people in their roles now. No wonder it's hard to keep leaders in their roles now. No wonder it's hard to keep the teams stable. We're dealing with very different inputs than we used to. With that in mind, I just want to say put a pin in that because I want to come back to that 9-point increase during the pandemic because we now know how to undo that size of an effect very quickly, which is encouraging. But we'll get to that here in a minute. This kind of leads us to where we are now. We just don't have the gas in the tank to do the kinds of things that we could have done before the pandemic when you were less emotionally exhausted. So we need to start with some simple strategies. We know that exhaustion is way up. Does it also have that social contagion thing in the Whopper? Yes, it does. In fact, we collected data across using work that we did with the Michigan Hospital Association. We tracked this across 31 hospitals in Michigan, and we actually found an ICC for burnout of 0.26. Let me just explain that. ICC is a measure of inter-rater reliability. Why would you have inter-rater reliability between healthcare workers in the same work setting? It's because it's not an individual difference. Let me just interpret that for you real quick, what an interclass correlation means. That means that for any one healthcare worker's emotional exhaustion score in the state of Michigan, you could predict it 26% of it by just asking the people to their left, people to the right, what their emotional exhaustion score was. Let me say that another way. A quarter of your well-being is who you work with. A quarter of your well-being is who you work with. I did not learn that in my training. I don't know if you learned that in yours, but that was news to us. Burnout's a team sport. We should be treating it as such. The interventions should be treating groups of people, not just individuals as well. So I like this. If you ever are looking for good fodder for presentations, I like to go to www.despair.com. We did anti-motivation posters like this. Burnout attitudes are contagious and might kill you. That's actually what the data show, is that this is not just me trying harder. This is like me being impacted by you and you being impacted by me. And so that requires a different level of focus. I also want to point out that your drama now becomes my boat anchor. So if you are a healthcare worker around other healthcare workers that are struggling, that can pull you down very reliably. And to be pulled down, does not mean that you're wrong or ill-prepared or less than. To be pulled down means that you're a human. Because the only category of human being that is not vulnerable to the suffering of others, like this, are sociopaths. With all seriousness, if you are not affected by others' suffering, you're a sociopath. So if you are affected, thank God you're not a sociopath. And for you, we need special kind of resources to make sure that you get what you need to bounce back. This is data from Kyle Rader on the emotional exhaustion and disruptive behavior, which I thought was really interesting. I want to pull in and just share with you. If you rank order, this is 319 work settings. If you rank order them from least exhausted, that's in the green, to most exhausted, that's in the red. So the first quartile, you're not as burned out. The red quartile, you're more burned out. And then you go and you look at things like, what's it like to communicate in the red work settings versus in the green settings? What kind of disruptive behavior prevalence do you see in the red work settings versus in the green work settings? And it's very linear. For every disruptive behavior that we looked at, whether it's bullying other people, publicly humiliating others, turning your back before conversation is over, hanging up a phone before conversation is over, making comments with sexual, racist, or ethnic slurs, and even showing physical aggression, it's linear. The more emotional exhaustion there is, the more you see disruptive behaviors. And the arrow goes both ways. And these data were collected before the pandemic. So the prevalence of burnout and the prevalence of disruptive behavior is much higher. And the link between disruptive behavior and the link with emotional exhaustion is much stronger now. So even before the pandemic, we knew that this was a real leading indicator. And it's not just disruptive behavior, it's who stays and who goes. This is the attention to belief scale that we were talking about earlier. If you say, I would like to find a better job, I often think about leaving this job and I have plans to leave this job within the next year, you're much more likely to come from one of those emotionally exhausted units. And 35% of all the people who say, I'm thinking about leaving this job, I want to find a better job, 35% of them are no longer with you 2 years from now. So using a scale like this, you can actually show the cost that burnout has on your workforce by going back and doing an ROI. So the good news here is that just like burnout's contagious, so well-being, burnout of others can pull you down, and the well-being of others can pull you up, and that's very exciting. I love this work from just prior to the pandemic. Having a happy spouse is associated with a lower risk of mortality. Congratulations, for every 1 standard deviation increase in spousal happiness, your mortality risk goes down a whopping 13%, which is a pretty big reduction in mortality. We used to say happy wife, happy life. I think now we can say happy spouse, long live your house. That's data we're showing. But it's not just spousal happiness, it's also depression. I've got 2 kids in college, and I'm here to tell you, I thought about this when I sent them off at the University of Notre Dame. They used to just take random freshmen, put them in random dorm rooms, but this particular year, they screened all incoming freshmen for depression, and they put into each dorm room 1 depressed roommate and 1 non-depressed roommate. And they tracked them both for depression 1 month into the freshman year and then 6 months into the freshman year. And what did they find? They found that 1 month into the freshman year, the non-depressed roommate had symptoms of depression. 6 months in, ding ding, they met the diagnostic criteria. But wait, there's more. If you look at the depressed roommate, 6 months into their freshman year, they were able to offload so much of their junk onto their unsuspecting roommates that they were doing significantly better. So, something to think about. It does, it goes both ways. It definitely goes both ways, and we have to remember that. So there's a social contagion for work-life integration, emotional exhaustion, spousal happiness, depression. Newsflash: if you measure it with precision, you find evidence for the social contagion. If it's well-being metric, that's what we're finding. The more you have a high response rate, a valid metric, you're going to find it. Now, with that in mind, let's peel back the layers of the onion just a little bit about what we mean by well-being. And what I really mean is your focus is what determines your reality. To kind of quote Morpheus in the Matrix, your focus is what determines your reality. If you show what you're looking at is what determines how you perceive the world around you. Your focus determines that reality. To give you a clinical example, if you show a CT scan of a lung to a referral radiologist, and you say, hey, you see anything unusual in this scan? Why is it that 4 out of 5 radiologists don't see the gorilla in the upper right quadrant there? I'll go back. You see it now. It's 23 times larger than the average nodule you're looking for in a cancer screen like this, but 4 out of 5 radiologists don't see it. Why do they not see it? Because the gorilla is dark. And you're looking for white or light colored nodules and a cancer screen like this. So if your brain is looking for threatening information, it disregards the non-threatening information to find the threatening information. That's useful. That's really good. But it also means that we have to be very tuned into well-being and how well-being impacts the way we interpret everything. I'll give you an example of this is Renzo Bianchi's work. He does gaze tracking studies where you put a helmet on people's head and you flash images on the screen in the helmet and you can gaze, you can see what they're looking at inside the screen. You can see what they're looking at on the screen. You can flash positive images and neutral images and negative images. And then you take off the helmet and you ask the participants, can you recall for us what you saw as we flashed those images? Why is it that burned out people like depressed people can recall with stunning accuracy the dysphoric stimuli? They can recall the negative images, but they cannot recall the neutral or the positive ones, especially not the positive ones. It's because when you're looking for threats, you find threats at the expense of noticing other things. From a biological perspective, from an evolutionary perspective, this makes a lot of sense. If you're actively running from a predator, what are you going to notice about the world in front of you? Well, you're going to notice other things that are trying to eat you or get in your way while you try to escape the threat that's behind you. Because if you're actively trying to avoid a threat and you notice a beautiful sunset, pause to appreciate that sunset. You're not going to pass your genetic material on to your children, your grandchildren. That's just kind of the game that we're all in. The problem is we use that same mechanism to deal with problems at work and to deal with problems at home in traffic and the prime lending rate and the outcome of a political election and a land war in Europe. And you name it. And that comes at a cost because now you go to work and you walk by absolute miracles every single day. They're still there, but you don't see them because you're actively involved in threat recognition. You're trying to find more problems. And this is what our brains are trained to do. This is not something that we're intending to. This is just kind of the default human condition. So if I can summarize for you real quick, a lesson that took me a really long time to learn, and I hope this makes sense, is that your well-being is the ability to see the good and the bad without focusing on one of those things at the expense of the other. If you're the kind of person who says, yesterday sucked, today sucks, tomorrow's going to suck, every day sucks, or if you're the kind of person who says, yesterday was a good day, today's a good day, tomorrow's going to be everything above ground is a good day, both of those people are annoying. They just aren't. Both of those things. Because if you wear your emotions like a t-shirt and you never change that t-shirt, that's pathology. That's not mental health. So being pathologically positive is not being well. True well-being is being able to say, yesterday sucked, but today's better. That's well-being. Seeing the current situation with clear eyes, whether it's good or bad, and calibrating your mood to the current situation as opposed to calibrating your mood to something that happened a long time ago. So real well-being is not being happy all the time. I just want to make sure that that's clear for people. Now, I'd love to demonstrate this, but maybe just in the interest of all of our viewers that are now online, maybe I won't, and instead I'll go straight to what I'll show you the juice. What we tried to do to pack all of this into as small of a package as possible for busy, tired, cranky healthcare workers is we put it into a virtual session for folks that was initially done as Zooms called Wellbeing. So we took these interventions that were simple and easy, and they didn't take very much time to complete. And we packaged it into continuing education format. So if you show up for an hour of CME or CEU, you get an intervention. And to do this, we went through the literature. We sifted through over 200 different interventions. And this is our first NIH R01 grant to do this at RCTs. And out of all of those interventions, we applied this criteria. For it to be bite-sized by our standards, it has to be very easy to do. It cannot take very long. I want to feel better right away, and I want to feel better for a long time. I don't want to feel better for an afternoon. I want to feel better for a long time. So if it met those criteria, it made it into the list of things that we're willing to try out in RCTs on healthcare workers. Out of 200 possible interventions, we found 5, maybe 6 if you're generous, but 5 that met that criteria. And that was the beginning of our bite-sized strategy. We now have 21 interventions on the website. They're all free and they're on demand 24 hours a day. But this is how it started out with those 5. The first time we published it, we did it in the neonatal ICUs across the country. We did this with my colleague Jochen Profit at Stanford, and we showed that we can cause, using a bite-sized intervention, we can cause emotional exhaustion to go down and stay down for 6 months. We can cause work-life integration problems to go down and stay down for 6 months. We then did a follow-up study. We just published this last year showing that not only did it go down at 6 months, it continued to go down at 1 year post. So let me just kind of pause and say, this is not a pharmacological agent. If you go off your SSRIs within a couple of weeks, the effect melts. If you stop doing this intervention after just 10 days and you look 6 months and 12 months later, it's as if you're still doing the intervention. So we call this skills, not pills. It changes the way so you can see the good and the bad and not be just always fixated on the bad of it is. We did get a lot of feedback from our neonatal colleagues, especially neonatal nurses, had a lot of opinions about how we should be doing the interventions. And we integrated that into the next couple of generations, and we learned a lot from them. The second time we did it, we didn't limit it to the NICU. We expanded it beyond the NICU, and we changed it from a 28-day intervention, where it was 1 or 2 minutes a day for 28 days, down to a 10-day intervention. So this is the second RCT. This is beyond the NICU, and here we show that we can cause emotional exhaustion to go down and stay down for a year. We can cause depression to go down, stay down for a year, work-life balance problems to go down, stay down for a year, et cetera, et cetera. And that was very exciting because you can see the same pattern where between 6 months and 12 months, emotional exhaustion continued to go down. That's the top gray bar there. And why that's important is because when you're doing an intervention that lowers your emotional exhaustion score from a 56 to a 46, that's a 10-point reduction. I don't know if you remember me talking about this earlier. COVID caused emotional exhaustion to go up almost 9 points over 3 years. We caused it to go down 10 points in 10 days. So it's a pretty significant clinical effect on well-being. So there's the difference. 9 points up in 3 years. We've got 10 downs using this intervention. The QR code is there. If anybody's interested, it's free. It's HRSA funded. It's evergreen. It's permanently available for free to anybody who wants to use it. And what I would suggest to you is that try that. If you've not tried it before, try that. If you like it, share it. That's my first recommendation. Find something that works for you and then talk about what you did and share that with other people. That's what we need more than anything. And more than this particular intervention, we need people talking about it and sharing what works for them. The WellBe is the most recent version of this. It's the same QR code. The most recent version of this is, instead of it being where we text you every day for 28 days or every day for 10 days, and then you do this little 1 or 2 minute activity through a text message, we now embed the bite-sized activity into a lecture like right now. So you're sitting here listening, and then we put up a timer, and you do the activity during the lecture so that there's no pre-work, there's no post-work, it's just you're done. And that's been a way that we've kept engagement levels up and that we've kept it accessible and feasible and useful for people who are missing. The 5 modules that we do are the science of gratitude, of work-life balance, of self-compassion, of cultivating awe and wonder, and then of group level well-being. So each one of those has its own CME and CEU hour that goes with it. So if you do one of those, you get 1 intervention. If you do 5 of them, you get 5 interventions. It's kind of that simple. It's all delivered now over the web. We used to have live sessions where you'd have to enroll in a cohort, wait for your cohort to start, but now it's on demand. So if you sign up right now, you'll be sent your first recording for your first hour today, and you have a year to watch it. You have a year to watch it and claim your continuing education credit. You don't have to do it today, but we do suggest you do them in order possible because there's a slightly better effect. We've been very careful about the sequencing of these interventions so that you're doing easier ones first and you're doing more difficult ones later on. We can talk more about that sequencing if you want later. But you get 5 hours of continuing education credit. For a hot minute, a colleague told me that it was trending on Java Network Open when we published this randomized controlled trial. I was super glad to get it for about 6 hours. It's trending. It's not trending. But here's the intervention. It's well-being healthcare workers after a 5-hour continuing education intervention. We were actually able to show that we can cause emotional exhaustion to go down. We can cause emotional thriving to go up. We can cause emotional recovery, which is how quickly do you bounce back after an upheaval, to increase. So we can speed up how long it takes for you to recharge your battery if your battery gets low. And we can cause work-life integration problems to go down. We had a waitlist control. So the moment the intervention was done for the treatment group, the waitlist control got it, and you can see they replicated all the findings. The second line in the series, all as you can see, replicates the first orange line. We were pretty tickled with it because all 4 interventions that we targeted improved a lot, and it didn't cost anything. That's the well-being intervention that we are hoping people can take advantage of. If you haven't grabbed it yet, you can use it either through the QR code or you can grab the bit.ly link, bit.ly/wellbe Duke. It's called Wellbe. You can text that link to people. You can put it in a newsletter. You can send it in an email. It's in my email signature, so it's really easy to kind of share access to this with other people. But it's about helping people with resources that are shareable, that are evidence-based, that don't take very much time to implement. With that, I want to back up a little bit. So now you've seen the intervention and you've seen a little bit of the research behind it. I want to just say I'm a big fan of Christina Maslach and what she did with the Maslach burnout inventory. She's brilliant. She was way ahead of her time. She created it in 1974. It's still the gold standard 50 years later. That's highly unusual for something to be the gold standard for 50 years. So kudos to her. It also costs money to use it, and I hate that. I hate that you have to pay money to use that inventory. So I'll just say again, I said this a couple of times today, we created a free version of that instrument so that you can still get the benefit of it, but not have to pay for it. If you want more information on that, you can search emotional exhaustion with Sexton. You can find it. It's free. It's an open access. Everything we do is open access, so that you don't. It's easy to probably Google. The 3 pillars, according to Christina Maslach, are emotional exhaustion, which we've talked about already. There's also depersonalization, where you kind of grow callous towards your patients or your colleagues. That's the second pillar. The third is inefficacy. You just don't feel like you're good at what you're doing anymore. Those are the 3 pillars of burnout. I can't tell you how many times I've sat in a room like this, talking to people like you, and I've talked about that. That's what burnout is. Until I talked to my youngest daughter, Tatum. I was picking her up from a soccer game, strapping her into her car seat, and she says, "Daddy, you are always talking about burnout. Burnout, 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 burnout. What is burnout, Dad?" And so I'm like, "Well, honey, burnout is emotional exhaustion, depersonalization, and a diminished sense of personal efficacy. You're not following what Daddy's saying. I don't know what any of that means. What's burnout, Dad?" It's one of those moments where you can't explain to your child what you've been doing for 20 years. Do you really know what you're doing? So you kind of take a breath and you say, "Okay, I'll tell you what burnout is. Burnout's what happens when it gets really hard to notice when something is funny. It's hard to notice when something is interesting or amazing. It's hard to feel grateful. It's hard to feel hopeful. It's hard to feel any kind of positive emotion at all when you're burned out." And she says, "Oh my gosh, Daddy, that is so boring." I used to tell all my friends you worked at Duke, and I'm not telling any of my friends that anymore. My sister was right. You are lame. That's what she said. Take that all in stride as a multiple children. But this Tatum definition, that we call it, really revitalized the work that we were doing, because rather than trying to meet kind of this kind of esoteric definition of the 3 pillars of burnout, we cannot say burnout's when it's hard to feel grateful or hopeful or any kind of positive emotion at all. And so now, if you can increase access to positive emotions, we watch burnout go down. And if you decrease access to positive emotions, we watch burnout go up. It's very linear. So with this definition, we published this, we've operationalized burnout in a different way. We now have a lever that we can pull on to change people's well-being levels very directly using this definition. All the research on positive emotions comes from Barbara Fredrickson at UNC Chapel Hill. She is by far the leader in this. She's been the leader in this for 35 years. Barb says there's joy, gratitude, serenity, interest, hope, pride, amusement, inspiration, awe, and love. And each of these positive emotions affect your well-being in different ways. Some of them are easier to access than others. I'll give you an example. Gratitude, I can turn on gratitude like a light switch. You can give me someone who is suicidal, who is anxious and depressed, and I can turn on gratitude in them in minutes. Hope is a very different story. Hope is tricky. You have to have some preconditions met to feel hopeful. Humor, very tricky. You have to have some preconditions met to feel like something is funny, to be able to laugh at something. So some of these are easier to access than others, and we sequence them in our interventions knowing that. I'll say this, though. I dare you to feel like you can make a difference at work and not feel one of these. You can't do it. It's just the way that you're wired. So with that in mind, it's through positive emotions that we feel like we're making a difference, and it's through positive emotions that we can recharge our batteries when our batteries get low. Now, with that in mind, I also want to say this is not my research. This is Barb Frederickson's research at UNC Chapel Hill. And for somebody to say something nice about somebody at UNC, she's pretty amazing. When it comes to positive emotions, it's not the magnitude that matters, it's the frequency. It's how often do you feel a little bit grateful? How often do you feel a little bit hopeful? Even microdoses of hope go a long way if they're repeated microdoses of hope. And that's a lot easier to do than to feel super hopeful or super grateful at any one time. And with that, that also allowed us to go back and we turned our 28-day intervention is now an 8-day intervention. And it's more powerful than the 28-day because we now have integrated these lessons learned about how to conceptualize it, how to turn it on, and everything we do from the way we interact with people in sessions like this to the way we interact with you through the intervention that you get on your phone. We try to make it engaging and interesting and useful in ways that can keep you doing it. So that's the big thing there is frequency, not magnitude. And then also, how do we kind of make this useful for people in real time? I'll give you an example of what this looks like for groups of people. We've published quite a bit on leader rounding. So safety rounding by leaders is where a leader goes into a work setting, and traditionally they'd say something like, "So, how are we going to harm the next patient around here? What can we do to prevent that?" And it was a great way to start a patient safety risk-related conversation in 1999. But in 2025, you'll get something heavy thrown at your head if you kind of walk into a unit and kind of start the conversation like that. So instead, we now use this positive emotion mindset to create psychological safety in that interaction. And now we say, using the positive rounding frame, we say, what are 3 things that are going well and 1 thing that could be better? And so now by talking about things that are going well despite the situation we find ourselves in, I now feel better talking to you about the pebble in my shoe that, boy, if you could just take care of this, it should make a difference. So you increase psychological safety, you increase trusted leadership and patient safety norms, and you reduce emotional exhaustion when you do this. So we put them into a horse race. The first time we did this, and the Joint Commission did a press release saying, "Hey, there's a new way of doing rounding. Do leaders ask about what's going well?" And we kind of break that into quartiles. The red, they don't ask as much. The green, they do ask a lot about what's going well. And in every safety culture, employee engagement, and well-being domain that we measure, you're much better off if leaders are routinely asking about what's going well. It creates trust. You're not just asking me about the deficits, you're asking me about the successes. So improvement readiness is a scale that measures your capacity to do quality improvement. So your capacity to do quality improvement is improved when you're asking about what's going well. I trust my medical director, my nurse manager, my unit manager more. When you ask me about what's going well, I can resolve conflicts. I can ask questions. My teamwork norms are better. When you ask me about what's going well, would I feel safe being treated here as a patient? Yes, my safety climate is better. If you ask me about what's going well, look at my emotional exhaustion is lower if you ask me about what's going well, and my burnout climate, which is how crispy are my colleagues, is lower. My colleagues are less crispy when you ask me about what's going well, and then even work-life balance is better when you ask me about what's going well. But wait, there's more. We did a whole nother publication where we looked at psychological safety. We put this in a horse race, comparing on the left-hand side safety rounding to the right-hand side looking at positive rounding. And while patient safety rounding works, I'm not disparaging safety rounding. I've done a lot of research on that. It's good. Positive rounding is better. It takes the same amount of time and you get more bang for your buck. You get more juice for your squeeze. So why not do it in a slightly different format? Psych safety is stronger in the positive rounding group. Even safety climate. You'd think that patient safety rounding would be better for patient safety climate, but actually patient safety climate is twice the effect in the positive rounding as it is in the safety rounding. Not only that, you can look at emotional exhaustion, you can get a bigger bump for emotional exhaustion. And so these 2 things together are how I conceptualize culture in a post-pandemic world. Psychological safety is, do I feel comfortable opening my mouth? And emotional exhaustion is, do I have charge of my battery to do stuff at work? And if you know those 2 variables, you know enough about what's going on in that work setting to know how much help they need or don't need and what they should be working on, how fast they should be going, and what they're working on. So this is an interesting way where culture kind of overlaps with well-being. I'll say this too, if you go back to the study across the 31 hospitals in Michigan, we have an item about leadership that I think is for leaders to hear is kind of helpful. In this work setting, my nurse manager / my medical director regularly makes time to provide positive feedback to me about how I'm doing. That one item that suggests you take time to tell me what I'm doing well. For every 10-point increase in that, there's a 28-point decrease in your burnout score, which is a really big link between how I view my leader and what my well-being is like for me personally. In my opinion, what is my well-being? So self-reporting burnout, which is how we measure burnout, is dramatically impacted by the way we view our leaders. And it's not just me. This is a lot of Gurdon's work and Colin West's work, and this is like the best science is when different groups study different populations and find the same thing. They found the same thing with this item. My immediate supervisor encourages me to develop my talents and skills, and they showed that actually predicts the same thing, the massive decrease in emotional exhaustion. Leadership is important, and you can apply this to individual level interventions, and you can apply this to group level interventions. The people that I'd like to call out, I talked about them this morning, is David Hurtado and Abigail Lemar, who at Oregon Institute of Occupational Health Sciences, they started the concept of well-being check-ins. So they started this work in primary care clinics, and they found that during the pandemic, there were some primary care clinics that actually showed a decrease in burnout, while most of them showed an increase in burnout. And they went to go study, and they did interviews and found out, in the clinics where the burnout went down, those were the clinics where the leaders were doing well-being check-ins. So what are well-being check-ins, and can we export that? And they've done 2 randomized controlled trials showing this now. It's pretty interesting. What they found is that if a leader spends 10 minutes 4 times a year checking in with staff about their well-being, how we're doing, what are you working on, what do you need from me, not that the leader can solve all the well-being problems of the staff, but if they carry it with the staff, that is a form of support that is as powerful as a powerful intervention, as a coaching intervention that costs a lot of money, therapy that costs a lot of money, medication that costs a lot of money. This simple thing that leaders can do goes a long way. And it's feeling supported at work. It's not feeling like my work can solve all my problems, but at least the person who I report to knows the kinds of things that I'm dealing with. And now I feel seen at work. 10 minutes, 4 times a year. Just to summarize, I've talked about a lot of stuff really fast. I'm trying to get to where we can have some Q&A because I know you all have a lot of questions. I want to make sure you have time to ask those questions. We know that well-being is a social contagion. The positive emotions are key to understanding these interventions. And if I give you another kind of useful tidbit from today, is if you're thinking about doing something for well-being in a work setting near you, ask yourself, is this thing going to increase access to positive emotions? Now, there's a difference between getting rid of stupid stuff, fixing Cerner, and then increasing positive emotions. So are you getting rid of stupid stuff, or are you increasing positive emotions? Increasing positive emotions has a direct causal link to people's well-being. You can ask yourself, is this thing we're doing, is it likely to succeed? Well, that's a new framework that you can use. And also we have shown several of these randomized controlled trials already, and we've got 2 more that are in the works showing that, this stuff works. With minimal effort, minimal time commitment, you can make an enduring difference in people's well-being. I say all this to say, the one thing that's not going to change is that there's going to be a lot more change coming at us. And so if you're in a leadership role, buckle up, because it's going to get even more tricky with every coming month, every coming week. It seems it's getting trickier, and we have to be ready for that. And in doing so, on our website, cause.dukehealth.org, and I just want to let everybody know I totally structured this after Sue Scott's approach of making things free, because I'm a big fan of Sue. On the left-hand side, you can see institutional resources, things you can do that are group level. And on the right-hand side, we have 20 plus interventions that are all meant to be bite-sized things that are on demand that individuals can do for their well-being. I'll kind of wrap it up by just saying, in addition to the 5 hours that are completely free, we have this 12-hour program that's monthly. Every month for 1 hour, we do a live session on a 10,000 line Zoom, and it's a different topic every month. We have one on hope. We have one on sleep. We have one on 3 good things, using your strengths. We have one on how to work with a jerk. We have one on how to process grief, or how to use humor. Lots of different topics. It's a diverse set of topics. It's not all yoga and meditation. It's a diverse set of things that you can do for your well-being. And if you add the the 5 hours we talked about before for well-being, these 12 hours, that is what we call our well-being ambassador training. That's how we give people the resources that they need to have options to deal with things. Because it's going to be very different from one work setting to the next, what you should focus on, what you should be working on, and what's going to really fit with the culture in that particular work setting. So having the options is the best way we know now to kind of prepare people for the stuff that we just really can't necessarily prepare for. If you're interested, you can follow us on LinkedIn. We release all of our articles, videos, tools, resources. We're always going to do a release on LinkedIn. Because of all the social media platforms, it's the least toxic that we can find. It's not toxic free, to be sure. But very few people are death scrolling on LinkedIn, whereas they are death scrolling on those other platforms. And so it's the least offensive options that I can tell. So that's just one way that we put it out there. And with that, I'd love to open it up for questions. I know you have a lot of questions.
Thank you. That was wonderful. We do have quite a few questions that have come in, and I want to, we were talking about this before we got started today. I want to thank everyone who registered and submitted these questions, really thoughtful, and we've kind of organized them. We were interested to see there were a lot of recurring themes. And so one of the themes that came out was as a supervisor or manager, how do we protect our staff that we oversee from burnout while not taking on it onto ourselves?
I think it's important to, I mean, I love that question, and that's like, we get that from very concerned leaders all the time. How much is too much and when it's diminishing returns? What I would say is you can't expect to solve everyone's problems. That's not your role as a leader, and that's not your role as a manager, is to kind of fix everyone's well-being. It's more to the extent you can role model these things. Like, don't just take lunch break. Say, you guys, I'm going to lunch because that's what you do at meal times. And you eat at meal times, guys. I'm going to lunch. Like, say, I'm going to the bathroom because that's what you do when you need to go pee. I'll be back. You know, if you can role model self-care in ways that are encouraging others to do the same thing, it's going to make it easier for you to take care of yourself if there's, you know, in the long run. That's one. The other is, and I think I saw another question related to this that was about that one person who's just so hostile or so negative.
Right. I actually had some extra notes that I was thinking about what you shared about 0.26 of that ICC, like a quarter of your happiness finds the people around you.
Yeah.
Because some of those questions I thought, well, this is very specific, you know, with one employee that's unhealthy, but during your talk, I thought, wow, it's actually really relevant.
Yeah. Without, like, I don't want to overblow the statistics on this, but it's not, it is true that one person can really pull down a group. Yes, that's true. And it's also true that some people are very happy to die of smoking. And they're not looking for you to fix them, right? And the same is true for well-being. So fix everybody. And when you realize that you're bludgeoning yourself against the brick wall and trying to do that, it's time to slow down and help the people who are ready to be helped. Because for every person who is the immutable force, there's many more who are like, so what am I supposed to do here? What am I supposed to do? How do I do this? And I think that focusing your energy on what you can fix is really helpful. And it really starts with this idea. I tried to say this before. Try something else, but whatever you do, talk about it. Tell your staff that this is what I'm doing for my well-being. What are you doing for your well-being? That simple act of just being a little bit vulnerable and saying, this is what do leaders do? They role model self-care. That's what leaders in 2025 do. I think it's important to be real about it.
Thank you. This was an interesting question that they were curious about the data comparing burnout trends for women versus men. Do you have any data on that?
There's quite a bit of data on that. Anytime you report like gender, in a study, you're going to find differences. If you've got a good response rate and a good metric, there's going to be a big difference. And this kind of came up earlier. It is simply a fact of life that it's harder to be a female in this world than it is to be male. It just is. On average, it's harder to be a female. And so females have, on average, higher burnout rates than males. They have, on average, worse work-life balance than males. And that is an effect that is larger than whether you're a physician or a nurse. It's larger than whether you're 50 or older or less than 30 years old. It's larger than kind of, where you trained or how you trained. It's a pretty powerful one. But I will say this, as much as that is probably demographically speaking, the biggest driver of well-being, it's certainly not perfect as a driver. And I think you're better off, rather than say, well, shouldn't there be interventions that are tailored to women and other interventions that are tailored to men? I think you're actually much better off understanding someone's well-being profile and saying, well, for somebody with your well-being profile, we actually recommend these strategies. And I think that's a much better strategy than trying to kind of isolate some group and develop an intervention for a group. There are certainly interventions that physicians favor. Out of the 21 that we have, I can tell you right now, physicians like the sleep intervention and physicians like the all-in-wonder intervention. They very much favor those interventions. Nurse managers actually favor those as well. Nurses favor the gratitude intervention, self-compassion interventions, the other ones on average. So there are things people are drawn to, but that doesn't mean that that's necessarily what they need based on their demographics. And I would much rather see the future, like a precision medicine, like a precision look, where if we're doing a brief assessment and we know your profile, we can make targeted strategies based on your well-being profile rather than try to put you into a demographic bucket.
And there's 21 tools.
Yeah.
To really.
Exactly.
Yeah, it's really, that's interesting. There's a question here. I saw in your presentation how you talked about the metric going down by 9 after COVID and coming up by 10 after a short time of using these tools. There was a question about latent COVID trauma, though. Is that more specific? And just seeing if you could have recommendations for frontline healthcare staff or any staff that has that.
Yeah, it's funny because I was talking about this in 2021 to folks, and I was saying, this stuff, if anybody who understands PTSD knows that the really bad stuff that's happening right now, it's not going to show up for a couple of years. And then it's going to be when you least expect it. And it's probably going to be on the anniversary of this thing that happened to you. And nobody was talking about that, but sure enough, we see spiking rates of well-being. And what I find to be very interesting is that nurses have shown a slow and steady kind of increase in emotional exhaustion. Kind of every year it just gets a little bit worse, a little bit worse, a little bit worse for nurses. Physicians shot up and caught up with nurses recently. And that is concerning to me because I'm hearing a lot more, holy crap, what do we do about this physician well-being stuff from my physician colleagues now that I never have before? And I think it's because they haven't seen the data yet, but they are hearing the scuttlebutt about this is not good. I've got way too many people that are not doing well relative to, even just a couple of years ago.
There's a few that kind of fall into this idea of, as a manager that I'm feeling, or as a supervisor, I have a need or I feel like there's an expectation of managing rather than coaching, and that I need to be a more domineering type of personality. And so, what kind of advice would you have for maybe changing the culture on my team or changing my own leadership strategy?
And I'm a big fan of regularly assessing culture with a valid metric, with a good response rate, and then using the debriefing of that to drive the priorities for the next 12 months in that work setting. That requires a data-driven approach where you're not reacting to the water cooler talk, but you're reacting to the incentives driven by everyone who works there saying what they need to be working on is how quickly they can tolerate some new change or intervention. Right now, the simplest lever to pull are going to be leadership-related interventions for a work setting because we have a lot of recovering to do to gain back trust that's been lost, and to kind of fill up people's batteries that have been depleted.
Yeah, I want to open it up to the people in the room too that did come in person. Are you? Oh, okay, go ahead. I have more questions, but I wanted to open it up.
I thought it was great.
Thanks.
Extraordinary. And I have like 6 or 7 questions, but I was going to ask. Okay, so we were where I was before working with a completely different population of people, and one of the things that we have noticed that enhances what everyone deems as resilience is belonging.
Yeah.
And belonging to a community of workers, belonging to a team, belonging to other things.
Yeah.
Makes one sticky to an organization, but also gives one some buoyancy in a struggling environment. I wonder if you might speak to that conceptual.
Well, I love that question. I love making friends.
Work for you and
So we created a scale called DEI climate back before DEI was a curse word, according to all funding priorities. And we since changed it to sense of belonging climate because that hopefully doesn't trigger all the bots to kind of remove our funding. What we found is that with 5 items, you can measure a climate, a group, a norm of belonging that predicts burnout. It's specifically emotional exhaustion and intentions to leave. And it's the second best predictor of intentions to leave that I've ever seen, second only to emotional exhaustion. So the only thing that predicts whether you stay or go more than your sense of belonging is how exhausted you are.
Yeah, so we had shown that in a series of different physician groups and frankly some other work groups in my prior environment that you were likely of intention to leave and or was the sense of belonging. So just wanted to get your thoughts about that. And thank you. And I have a billion other questions, but I'll see you right now.
There's some really cool research that's being done on that. And frankly, I think we need to put good metrics behind concepts like that because very enthusiastic people got in front of the data and kind of muddied the water about how to go about fixing those things. And with all due respect to my colleagues in the DEI world, there are so many people that could have been in the tent with us. We pushed them away by saying they were wrong instead of showing them how to be part of something better. And so I think that we have to tread very carefully in that area to not lose people who are naturally on our team and making things better. But pace of change, right? If people aren't ready for change and you keep foisting it upon them too quickly, you have to be ready. There's going to be blowback. So we have to be, which is kind of like the outcome of the 2024 election. So
I have a question that came in from registrants and a question on, are the metrics helping us give better care?
Are the metrics helping us get better care?
On well-being, so improving well-being scores. Are we seeing better patient care?
Yeah, I started with the slide that we was talking about, this predicts employee engagement, this predicts medication error rates, this predicts standardized mortality ratios. So absolutely. In fact, the best predictor of any clinical outcome I've ever seen, and I've dealt with I've created a lot of predictors. I didn't create emotional exhaustion. I've created predictors that predict outcomes, but I've never seen anything predict outcomes in healthcare like emotional exhaustion does. There's nothing comes close.
Then one more question I think that I've seen this a few different ways, but I'm burned out on the conversation of burnout.
Yeah.
And do you think that lies into, I'm getting jazzed about thinking about these easy tools. Do you think that's more about not having anything be effective yet or not seeing it role modeled like you talked about, or is it something different?
I think when you give a drowning person the assignment of envisioning a world where everything is going well, it's kind of it's lost cause. And when you're just feeling so overwhelmed, the last thing you want to do is empty your mind of all of your thoughts and put your ankle behind your head and make sure that you're breathing deeply and noticing your breath go through your nose. I think that stuff is very useful, and the evidence behind meditation is profoundly good and real. But there's a time and place for something that's hard, and there's a time and place for something that's easy. And so it's a matter of when do you apply which intervention in which scenario. That I think that we've been kind of ham-handed in doing that. We think that if you talk to somebody who's a fitness kind of person, they think you just need to exercise more. If you talk to a nutritionist, you just need to eat better. And if you talk to somebody who's into meditation, you just need to spend 45 minutes a day for the rest of your life doing this one thing. I think that diet, exercise, meditation, and yoga have fabulous data behind them, and they're all very hard when you do them the way they're intended to be done. And so a lot of this came out of my personal desire to get to a point where I could do those harder things. And that was why we think of the bite-sized stuff as the gateway drug to the harder stuff.
Okay. Thank you.
Can I ask a follow-up question? In response to that gentleman that just left about belonging.
Yeah.
So that's not anything that you talked about in your presentation, but have you done work looking at your interventions that you've talked about and in relationship to impacting or improving a sense of belonging?
So we just validated this belonging climate metric in the fall of 24. We haven't implemented that particular metric into our interventions yet, but I will say we did this in 17,000 long-term care facility workers across the state of Pennsylvania. And the results were just like, they blew me away. The psychometrics of that metric are really strong. And the fact that it predicts, turnover so well, I would absolutely put that in a pre-post in any of our studies going forward. But to date, we have not done that yet. So that was separate research.
Thank you so much. And we have some more questions, but we can move some of those. Hopefully some of you who are in leadership roles have signed up for our afternoon leadership workshop. I'd like to turn it back over to Coach Joy to close us out.
Well, this was our third talk today, our third time gathering, and I learned something new every time we have the opportunity to sit down with you. And this was really useful. You've given us good information, and we're all very interested in improving the well-being of people that surround us. So thank you for your time. I appreciate it.